Good afternoon, everybody. Today's topic is blood components and blood transfusion. It's a rather vast topic. I'll try and compress it as far as possible, but at the same time, hopefully you'll be able to understand what this whole thing is about. So when we talk about blood transfusion, there are various ways in which you can do it. The commonest, or the one that was initially used, was whole blood transfusion. That is, you take the blood from one person and give it to another person. Quantity always, so that is called whole blood transfusion. Nowadays, this whole blood transfusion is very rarely used in the civilian setting. So nowadays we use what is called blood components. That is, the whole blood is taken and it is separated into its various components like RBCs, platelets, plasma, cryoprecipitate, granulocyte, like that. You get a whole lot of things that you can derive from the blood, isn't it? So instead of giving the whole blood, you give whatever component the patient requires. That is what we mean by blood components transfusion. And finally, nowadays there are experimental studies to look for blood substitutes. Getting blood is not easy. There is no, as of now, the only way you can get blood is somebody has to donate it. There is no other way. It does not grow on trees, or you know what I mean. Yeah. So you have to get it from another person. But now we are doing experiments to see if this blood can be substituted. See, we can increase the volume of the blood, the vascular volume in a patient by giving IV fluids and all that. But the oxygen carrying capacity cannot be mimicked by any of these IV fluids. Oxygen carrying, as of now, can be done only by hemoglobin and RBCs. So you require something to carry oxygen. That is the whole problem we have. We can give proteins, we can give all sorts of other things, but oxygen carrying is something which we have still not been able to do artificially. So people are working on that. Yeah. So this is a list of some of the blood components. It's not exhaustive. But most of the common things are included here. Packed blood cells. This is what we most commonly use. That is, when a patient has bleeding, what we do is, when the patient has a low HP, what we give is packed cells. I told you whole blood is very rarely used. Two reasons. One is availability. Storing whole blood, large quantities of whole blood is not easy. So nowadays it's whole blood can be used in a setting where you have a lot of people, like for example in the army, military, where everybody's blood group is known, and you know where the person is. So if you require whole blood, you can call one of them and ask them to be transferred. It is also being done nowadays in civilian practice. We have a blood registry where you have a list of people who have particular types of blood groups. So you can call them up when you want. But this is not easy. It is not commonly done. You use blood components. So packed red blood cells is the most commonly used blood component. Then you have platelet-rich plasma. When I say platelet-rich plasma, what I mean is it contains plasma along with the platelets, because the plasma can be, you can separate out the platelets from the plasma. So then what you get is platelets one side and you get fresh frozen plasma on the other side. So you can separate it into these two. Again, centrifugation, the top will contain the plasma, the bottom will contain the platelets, so you remove the platelets. So when a patient requires only platelets, for example, the patient has thrombocytopenia. Probably in our setting, the commonest example we can give is dengue fever. A lot of people, dengue fever, they have thrombocytopenia, and then sometimes you might have to give platelets, so you can use that. Fresh frozen plasma, the thing is, it contains all the other components of the blood. It does not contain RBCs, it does not contain platelets. It contains all the coagulation factors. That is the greatest advantage of fresh frozen plasma. Besides, it contains albumin and all that. So if you want to give albumin, probably you can use fresh frozen plasma, but it is a waste of a resource. You can give albumin in other ways, or proteins and other. So fresh frozen plasma, probably the greatest use is when you want all the clotting factors which is present in fresh frozen. Then you have cryoprecipitate. Like that, a whole lot of things are there. We'll go into each of these individually. So we'll start with whole blood. Whole blood, I told you, is collected from a donor and it is stored between 2 and 6 degrees centigrade Celsius, And you can use various preservatives. The problem with blood, as all of you know, is it will clot, isn't it? Once it goes out of the body, that clotting, that coagulation cascade comes into play, and the blood will clot, and then you cannot use it for anything. You understand? Yeah. So you have to prevent clotting, and then you can probably also add a preservative, to keep the blood viable for a longer time. So what we use is, in the olden days, what was used is, when I say old, I mean fairly recent past, acid citrate dextrose. The problem with acid citrate dextrose is, when you use this for this thing, for storing blood, the hemoglobin loses its oxygen carrying capacity, because you require phosphates for that to produce ATP, which is required for active transport and all that stuff. So because the phosphate is lost, what happens is, you store the blood, and when you give it to a recipient, it takes 2 to 3 days for this hemoglobin to become metabolically active, for it to start carrying oxygen. So till then, it is working only as a volume expander. It is not carrying oxygen. You understand? That is the problem. So then they came newer preservative like citrate phosphate dextrose was used, where as you can see, phosphate is included. So the metabolic activity is much faster. I told you fresh blood, there is no problem, because it is metabolically active. That is one advantage of fresh blood. I will come to that later. Whereas in stored blood, the metabolic activity is lost. Besides other things are lost. I will come to that later. Anyway, yeah. So that is why we started using citrate phosphate dextrose. Nowadays we have an even better preservative, that is citrate phosphate dextrose adenine. This preserves the blood for a longer time, and it has the metabolic activity quite quickly, unlike ACD. Yeah. So then coming to the shelf life, once you store it, how long can you store it before you have to discard it? You should not ever have to discard blood, but sometimes this happens. Yeah. So if you are using CDPA, that is citrate phosphate dextrose adenine, you can keep it for 35 days at 2 to 6 degrees centigrade. All right. Older days I told you, ACD we used to be able to keep it only for 21 days. With CPD, little longer, 28 days. But nowadays, either CPD or CPD-A1 is used, and up to 35 days it can be stored, and you can give it to a patient for transfusion. Whole blood. Right? Yeah, I was talking to you about fresh and stored blood. I told you fresh blood is the best thing to replace when there is blood loss. Blood loss, acute blood loss, best thing is fresh blood. The problem is availability. So, but the advantage of fresh blood is, I told you, it is metabolically active. It contains all the coagulation factors, and because it is whole blood, it will expand the volume also. Besides oxygen carrying capacity and the clotting factors, it will expand the volume also. Stored blood, the problem is, I told you, it is not metabolically active. So that is one. Two, the platelets lose their function. In the stored blood, after some time, the platelets lose it. Similarly, the leukocytes also lose their coagulation factors, get depleted. And this is the problem with, if you store blood at this particular temperature for a certain time, this is what happens. So ideal would be, when you want whole blood, ideal would be fresh whole blood. Yeah. But because it is, I told you, logistical problem, you can't have people walking around in the hospital, all over the place with, waiting to donate blood at the drop of a hat, isn't it? So it takes a little time to call them, get them and all that. So in an emergency, probably you require stored blood. Anyway, so that is about fresh and stored blood. Now when we draw blood, we usually draw from a donor, a unit is usually about 450 ml. And when you transfuse this is transfused over about 4 hours. That is the time usually that is taken. I'm not talking about massive transfusion here, but a routine transfusion. You transfuse 450 ml. That is 1 unit. It's called a unit of blood, whole blood, over about 4 hours. Yeah. So again, I just reiterating the advantages of fresh blood. I told you it contains RBCs, which are fresh blood, contains metabolically active. It can carry oxygen immediately, no problem. It expands the volume because it is whole blood, and all the coagulation factors are present. Now the indication for using whole blood nowadays is only when there is acute massive hemorrhage. Massive 15% is not actually massive, but anything over 15 you might require. For example, if you have a patient who is coming with a road traffic accident, continuing to bleed and his HB is below 8, or he's lost more than 750 to 1000 ml of blood, you may probably have to give whole blood. Now this will depend upon a lot of other factors, the age of the patient, the comorbidities the patient has, the physical state of the patient, all sorts of things. But as a general rule, active bleeding of large quantities of blood requires whole blood whole blood transfusion. We may not always get fresh, but at least whole blood. Yeah, so that is about whole blood transfusion. Yeah, so this is again what I just told you. Indications for whole blood transfusion, I told you active hemorrhage is probably the commonest indication. Then if you have patient with anemia who requires emergency surgery, again during surgery there is a lot of stress, requires more oxygen carrying capacity, so you will probably correct that by giving whole blood. You can correct that by giving whole blood. Similarly, symptomatic patients with anemia, probably you can give whole blood. I told you these are all relative contraindications. Probably the absolute contraindication is the first one, where there is acute ongoing hemorrhage. All right. Yeah. So yeah. Now who can donate blood? Yeah. This again is not exhaustive. I've just given a small list of things. Usually, a patient can donate up to 450 ml. That is 1 unit of blood. Thrice in a year, 3 times, every 4 months, you can donate blood. So any fit people can. There are a lot of voluntary donors who donate blood regularly. That is how we get blood when we want it for surgery and all sorts of things. Before the blood is donated, you will have to test the person for HIV, HBsAg, HCV, syphilis, malaria, and a lot of other CMV. Depending upon the prevalence in that particular region, there are other tests that are done. But these are HIV, HBsAg, HCV, syphilis, malaria, and all are tests which are almost routinely done. And then obviously you must know the group of the patient, the group and the type, that is ABO and the RH type of the patient must be known. Age, very young children and old people do not donate blood. I think the range is between 18 and 15 years, 50 years, 18 years to 50 years. Now this keeps changing, so I don't take this as absolute, but yeah, that is usually the range. Weight, the patient should be at least over 50 kilograms. Obviously, you must not have comorbidities which will interfere. You must not be having active diseases which can be transmitted by blood. A lot of other comorbidities. You should not have any other comorbidities which will be. Yeah. I told you this list is not exhaustive because of the whole list which you can look up. Yeah. But this is to give you a general idea. The patient has to be fit, and these criteria must be fulfilled before he can donate blood. Yeah. So that is about whole blood. See, packed cells, all the other components, all those tests that I told you about HIV, all this is relevant. HIV, HBsAg, HCV, all these things are relevant for all donors, all components. All right, I gave you this along with the whole blood. That's all. Yeah. So packed. Then we come to packed red blood. I told you this is the component that is most commonly used. Here again, the additives, just like we talked about whole blood, the preservative additives used are CPD, CPDA1, and then we have saline adenine glucose mannitol. Glucose is necessary for the metabolism of the cells, the stored cells, Yeah, the adenine similarly, mannitol, yeah. So as a preservative and diuresis and all that. So yeah, the best preservative that we can use for packed cells is SAGM, saline adenine glucose mannitol. And the advantage of this is you can preserve it for a very long time, up to 42 days if you use SAGM. Again, this is maintained at 2 to 6 degrees centigrade, which is Celsius, which is not very difficult, you understand? Now, if you freeze the RBCs using, you add 40% glycerol and then freeze it to minus 65 degrees centigrade, it said that you can keep it up to 10 years. Packed cells can be preserved it can be used up to 10 years, Alright, I told you packed cells are derived from the whole blood that the donor gives, and I told you our donor gives around 450 ml of blood. So packed cells constitute about 55% of this. So it will work out about 300 to 350 ml. You understand? 1 unit of packed cells. Now, why do you use packed cells? I told you packed cells are used for packed RBCs. When I say packed cells, please, it means packed RBCs. Packed RBCs contain hemoglobin, which is what carries oxygen. That is why we give packed RBC. So when a patient who has low hemoglobin, or a patient who is bleeding, where the hemoglobin will definitely come down later, you will give this. So this is where RBCs, packed RBCs come into play. So the indications I told you to increase basic, unlike whole blood increases the volume, increases the coagulation factors, increases the oxygen carrying capacity, all that. Whereas packed blood cells, only thing it will do is increase the oxygen carrying capacity, and that is what is usually necessary in most patients. Yeah. So we can use it for treating chronic and symptomatic. See, chronic anemia patients, you will find a patient with HB of just 5 or even 2. I've seen, we used to have, nowadays I think it is not that common. Not seen that frequently. 5 walking around happily, no problem. He'll have a little edema of the feet, and when you look at him, he'll be paper white. But he'll be doing it, and he might have a little dyspnea, after walking for 1 kilometer, he'll have a little dyspnea. But he'll be able to function, you understand? But if this patient comes for surgery, or if this patient has a trauma, accident, he's going to bleed even more, you understand? And then his HB is going to drop over, and then he will not be able to tolerate it. Because the anemia has developed gradually, the patient body is able to tolerate it. But when there is a sudden loss of blood after that, he will not be able to tolerate it. So obviously we'll have to do this. Yeah. And sometimes the patients are symptomatic, even with anemia. So then obviously you have to treat it by, and symptomatic, especially they symptomatic and not responding to conservative treatment. By conservative treatment, I mean you give him iron orally, you give him injections of iron, you give him all sorts of things. It's not protein and all that. Yeah, so that is one indication. And as I told you, actively bleeding patients, which they have to their RBCs have to be replaced. Massive hemorrhage has to be replaced immediately. Now we have something called a transfusion trigger. What do I mean by this? Transfusion trigger, as the term implies, is when will you give, at what cutoff will you give RBCs? That is the thing. So for a routine surgery when a patient with no other major comorbidities, an HB of 8. In the olden days, when I keep saying older, about 30 to 40 years back, we used to say 10. The hemoglobin level must be 10 if you want to take the patient up for routine surgery. Routine surgery, yeah. But now it is believed that 8 grams per 100 ml is enough. If a patient has an HB of 8 grams per 100 ml, you can take him up for most routine surgeries, like for example a hernia or a fistula or a mastectomy or a thyroidectomy. All these things can be done, but you will always keep blood in reserve in case it is necessary. You understand? But if the patient has comorbidities, especially if the patient has coronary artery disease, then you will have to maintain the HB at 10. So the trigger in a normal person without any comorbidities is 8 grams. In a patient who has a coronary artery disease or cardiac problems is 10 grams. So if the HB is less than 10 grams, in a patient with coronary artery disease requiring surgery, you will transfuse the patient to build him up. That is, if you are going to do it immediately. If you are going to do the surgery after 2 months, you can probably give him iron and build up his hemoglobin. You understand? So this is for, I hope you understand the situation. Yeah, you think over it. Now each unit of RBC will increase the HB by 1 gram per cent and the HCV or the PCV or the hematocrit by 3%. Yeah. When you give RBCs, what can you give along with it? See, you are giving an RBC from with a drip set, isn't it? A blood set. It's called a blood set with a filter and all that. You give it using that. You cannot give all sorts of solutions along with that. In the same line, you cannot give other things. The things that you can, most things cannot be given. The things that you can give are normal saline. You can give normal saline along with that. You can give ABO compatible plasma along with that. You can give albumin 5%, and you can give plasmalite, isolite, plasmalite, various mixtures of fluids that are commercially made, but they should be isotonic. The thing is, it should not contain calcium. They should be isotonic and it should not contain calcium. So you cannot give ringer lactate. That is probably one of the commonest fluids that we use in the theatre. You cannot give ringer lactate along with the packed cells because it contains calcium, and that will produce the blood preservatives contain chelating agents which takes out the calcium. So if you give fluid which contains calcium, what will happen is the blood will clot. You understand? The way the blood is the clotting in the preserved blood is prevented is by preventing the calcium from acting. Chelating enzymes remove the calcium, binds with the calcium. But if you give extra calcium, then that action is lost, so the blood will clot. So you will not give renal-lactate. Similarly, you cannot use hypertonic or hypotonic solutions, like for example 0.45% normal saline, or antibiotics should not be given, or any other drugs for that matter. TPN, all these things cannot be given. This is very important to remove, because see, we learn a lot of theory, but in practice these are the things which are finally important. Then we come to fresh frozen plasma. I told you fresh frozen plasma is obtained after removing the platelets from the plasma. You remove the RBCs and the platelets, then you get fresh frozen plasma. You also have what is called platelet-rich plasma, where only the RBCs have been removed. Everything that is remaining after removing the RBCs is called platelet-rich plasma. Now this platelet-rich plasma, you centrifuge it and remove the platelets, then it's called fresh frozen. It's called plasma, then it is frozen, so you call it fresh frozen plasma. Alright? That is, the thing is, it must be frozen immediately. That's the thing. The time gap between the collection and the freezing is immediate, about 6 hours, I think within 6 hours. So that is very important. That's why it's called fresh frozen plasma. You understand? If you keep it for a long time, I told you it will lose all sorts of, a lot of activity, most of its useful activity. So you have to freeze it immediately. That's why it's called fresh frozen plasma. Yeah. And it's stored at minus 18 degrees centigrade, unlike whole blood and RBCs, which can be stored at 2 to 6 degrees. Here you have to lower the temperature even more. So see, a blood bank is a very complicated place actually. And complicated, yeah, there are a lot of things that you have to worry about in a blood bank. You have to keep these things at the correct temperature, so the machines must work properly. Lots of problems are there. Anyway, now fresh frozen plasma at minus 18 degrees centigrade has a shelf life of about 1 year. Again, here if you freeze it to more than minus 65, you can probably use it even after 6 years. And 1 unit of fresh frozen plasma is around 200 to 250 ml. The advantage of fresh, I told you, whole blood, I told you this thing. RBCs, I told you, mainly for oxygen carrying. Fresh frozen plasma, it contains all the clotting factors, it contains fibrinogen, and it contains proteins. Most of the proteins are there in the fresh frozen plasma. That is the advantage of fresh frozen plasma. So you can use it for replacing any of these things, clotting factors, fibrinogen, or even proteins, albumin. As albumin substitute, you can use it. But the problem is 200 to 250 ml is the maximum that you get from 1 unit of whole blood. So you just imagine how much of blood you will require to replace the albumin, to bring up the albumin by 1 gram in a patient. You require large quantity. So yeah, so that is the problem. Now if you use about 10 to 15 ml per kg, that is in a 50 kg person, you will have to use about 500 to 750 ml of fresh frozen plasma. If you use that amount of fresh frozen plasma, it will increase the clotting factors by about 15% and the fibrinogen by about 40 milligrams per 100 ml. So it helps you to calculate how much you have to give on a patient. You can calculate the deficiency of the patient, and you can calculate how much you have to give to replace it. See this? Yeah. So as I was telling you, the greatest, the use to which it can be best put is for replacement of multiple clotting factors. Like for example, a patient with liver disease, chronic liver disease, alcoholic, he's got cirrhosis, chronic liver disease, he's come with massive hematemesis due to esophageal varices, and you are going to take this up, a patient up for surgery for something. This patient's, as it is, his liver function will be poor. Because his liver function is poor, he will not have clotting factors, so his blood will not clot. You understand? So in these patients, you can use fresh frozen plasma to bring up the increase the clotting factors, so that you can do surgery safely. Or patients who are on anticoagulants like coumarin, warfarin, coumarin. I'm sorry, coumarin. Anticoagulants, where again, anticoagulants act by reducing the clotting factors, isn't it? So here you can use, you want to reverse it. Supposing the patient is bleeding, patient is on anticoagulant for some reason, say for example he has atrial fibrillation, he is on anticoagulant, then he sustains some, he gets involved in a road traffic accident, he starts to bleed. The bleeding will not stop because he is on anticoagulants. So you stop the drug, that is fine, but still the anticoagulants will keep acting for some more than a day at least, So you have to stop the bleeding. You can use fresh frozen plasma. Then when you give massive blood transfusion, the problem is they tend to develop what is called DIC. So again, coagulopathy, so again you can use fresh. So fresh frozen plasma is a very valuable resource, especially in a situation where there is deficiency of multiple clotting factors. Then we come to cryoprecipitate. Now this cryoprecipitate, see, I have not gone into the finer details of the mechanism of separation of all these things. It's not easy. It requires, you'll have to ask a blood bank officer to tell you exactly how this is done. I can only give you overall, what should I say, a bird's eye view of how all this is done. So what I was telling you is, so you have whole blood, you have remove the RBCs, then you have platelet-rich plasma from which you can remove the platelets, and then you have fresh frozen plasma, that is, it is frozen immediately after removal of the platelets within 6 hours. Fresh frozen plasma. Now this fresh frozen, I told you it's maintained at minus 18 degrees centigrade. You thaw it, that is, you bring it up to about minus 4 degrees centigrade, and then the precipitate is what is called platelet. This slide is wrong. It's called cryoprecipitate. So supernatant you will have, and the thing that you get at the bottom, the precipitate is cryoprecipitate. Now cryoprecipitate again contains most of the clotting factors, and especially factor 8, and it also contains fibrinogen. So that is the advantage. So when you want factor 8, probably cryoprecipitate is your choice. You can get factor 8 concentrate, not just cryoprecipitate, but pure factor 8 concentrate. So that is even better than. So this is in a specific deficiency. You understand? Unlike fresh frozen plasma, which can be used for all coagulation factor deficiencies, here only a specific deficiency like factor 8 you can use this. It can also be used to replace fibrinogen, but I told you it is not cost effective or this thing, because see, the amount of cryoprecipitate that you get from a unit of blood is very small. So you require large quantities of blood to get enough sufficient cryoprecipitate to replace fibrinogen. For that you can use fibrinogen concentrate. We will come to that. Usually fibrinogen, I told you, it's used you use 10 units at a time. Each unit contains only 5 to 15 ml. You understand? So 10 units at the maximum will contain 150 ml. That's how it is given, and it's used as I shown here in treating factor 8 deficiency, that is hemophilia and von Willebrand's disease. That is factor 9 deficiency, isn't it? Then we come to what is called prothrombin complex. Prothrombin complex this is derived from pooled plasma. Plasma from a lot of patients is taken, RBCs removed, plasma taken from a lot of patients, and then from that you derive the prothrombin complex concentrate. This contains factors 2, 9 and 10. You can also add factor 7 to it. Now this is mainly used or is exclusively used for reversal of anticoagulation when the patient is on warfarin. Previously we talked about coumarin. Here it is warfarin. Again, warfarin is an anticoagulant that is used for all sorts of things. So if the patient is on warfarin and he has a bleeding due to any cause and you cannot control it, control it, you will use prothrombin complex concentrate. The other thing is, I told you can stop the warfarin, but by the time the clotting effect of the warfarin goes off, it will take about 2 to 3 days. By that time, the patient would have expired. You understand? Continue to bleed and expire. So, when you want immediate control of the bleeding, this is what you do. You give prothrombin complex concentrate. I told you you can extract factor 8 and factor 9 specifically, concentrates, not, yeah. So previously I talked about cryoprecipitate which contains these, but you can extract these factors alone or almost exclusively. So if you are sure hemophilia, the patient must have had a diagnosis, or even if you diagnose it for the first time, if you have made a diagnosis of hemophilia, you can use factor 8 specifically. You don't have to give cryoprecipitate or whole blood or platelet-rich plasma or anything like that. You can use, if it is available, you can use. So it is available. So there are situations where, there are, what should I say, apocryphal stories said about people undergoing surgery without knowing that the patient had hemophilia. And then on the table you detect that the patient has hemophilia. I'm not talking about major surgeries, minor surgeries. Usually this happens with circumcision, Circumcision, especially ritual circumcision or religious circumcision, you do it without giving without doing any investigation, baby or a boy, no problem. And then when it starts bleeding, it does not stop with all your, you do everything necessary to stop it, does not stop. Then you think of hemophilia. And then you're desperate, you don't know how to stop the bleeding. Then you start hunting around for factor 8. Yeah, so this is what happens. This is a story I heard. I don't have a personal thing, but there are many stories about this. Especially I told you circumcision and hemophilia. As you go along in your life as a medical professional, you will hear more of these. Yeah. Then you can get fibrinogen from this. Now from this plasma you can derive fibrinogen, alright? Fibrinogen, again, when there is a fibrinogen deficiency, you can use fibric concentrate. It's usually available as a powder, and each vial contains about 900 to 1300 milligrams. So you have to reconstitute it with distilled water, 50 ml of distilled water. And indications, as I told you, hypofibrinogenemia. Sometimes the patient's fibrinogen does not work properly. Dysfibrinogenemia. Sometimes they don't have fibrinogen. So the trigger in a patient with hypofibrinogenemia, the trigger is supposed to be like if the fibrin level is less than 0.8 or 1 gram per 100 ml, you must give fibrinogen concentrates. Alright. I told you this can be done by giving whole blood, but if you want for giving 1 gram of fibrinogen, you'll have to give probably 1 liter of blood or 2-3 liters of blood, which will overload the circulation of the patient, you understand. So there are a lot of problems involved here. So that is why we try to use components specifically for each indication, each situation. Yeah. So in hypofibrinogenemia, you can use fibrinogen concentrate. Then I already told you about the platelet-rich plasma, isn't it? Yeah. Now this platelet-rich plasma can be used both as a therapeutic or as prophylactically also. Like for example, if you're giving a massive blood transfusion, you might have to give platelet-rich plasma along with that to prevent coagulopathy. Yeah. So coming to some of the specific triggers for platelet-rich plasma infusion in surgical patients. If the patient has disseminated intravascular coagulation is usually an end result of all shock. Any type of shock, end result, one of the end results, or massive transfusions. If you give, again, you can have disseminated. So in these patients, if the prothromb or the thrombocyte level is less than 20,000 to 50,000, you will give platelets. Major surgeries, when a patient who has leukemia and the thrombocyte and the platelet count is less than 50,000, you will give like that. These are some cardiopulmonary bypass. Neurosurgery, the threshold is a little higher. It's 1 lakh. The reason is bleeding into the cranial cavity produces increased intracranial pressure and all its problems, coning and all sorts of problems. So you don't want the pressure to build up too much there. So that is why the threshold is kept higher. Anyway, yeah, another thing to remember about platelet-rich plasma, that is platelet transfusion. I'm talking about platelet transfusion here. Platelet-rich plasma is when hypothermia decreases the function of platelets. I told you stored blood as such decreases the function. So especially in a hypothermic situation, the function is even lower. So you must bring the transfusion fluid back to the body temperature before you transfuse it. Yeah. So this is generally about blood components and how they are used. All right. when I talk about platelet-rich plasma, I'm talking about platelets, all right? Please, it's used interchangeably. Then we come to complications of blood transfusion. See, it is not just enough to give blood, you must know what are the problems that you can cause, isn't it? So now this can be discussed under two headings. You can discuss, so you can have a patient who requires a single unit of blood. You understand? When I say blood, please understand this also includes blood components, all right? I'm not going to keep on saying, I'll just say blood. So transfusion, or I'll say transfusion. So the blood components also cause a similar problem, you understand? Don't think just I'm giving only fresh frozen plasma, no problem. So it is just like blood. You understand all the most of the problems you get along with that also. So yeah, so single transfusion and massive transfusion. I'll come to what I mean by massive transfusion later on. So single transfusion, these are some of the complications that you can get. I told you before you transfuse blood, you will cross-match the blood, major cross-match. That is, you will cross-match the serum of the patient with the RBCs, or the cells of the RBCs of the donor. You understand? That is called a major cross-match. You usually don't require a minor cross-match, but you might have to do it in certain situations. We won't go into too many details about that. So you must make sure that the donor blood is compatible. When I say blood, again I am telling you, it also includes blood components, alright? So it is compatible with the recipient. That is first thing. So when you are going to transfuse any blood component, you will double check the label to make sure that it is the correct recipient, correct donor, correct blood group, date of the date of collection is correct, that is the shelf life is all right. All these things must be checked. Not only you, it is best to check, ask somebody else also to check it. So two people will check it before you start a transfusion. You understand? So because why we are stressing this so much is that the commonest cause of incompatible blood transfusion reactions is because the wrong blood is given to the wrong patient. You understand? And this most commonly takes place because of a clerical error. This is either the blood bank sends the wrong blood and nobody worries about it, it's given, or the labeling at the blood bank is done wrong, something like that. It's a clerical error usually, you understand? Nobody will deliberately give wrong blood, isn't it? So usually clerical error somewhere along the because see, blood is donated in one place, it is stored in another place, then it is issued by another person, it is carried by another person to the site where it has to be transfused, and then it is transfused. You know, so many people are involved in this. So unless the protocol is followed properly, and unless you check it before the transfusion, you can occasionally give rise to very fatal problems. So one of the major problems that you can have is incompatible hemolytic transfusion. I told you this is a human error which should not happen. I'll come to that later. I'll come to each of these things later. Then you can have febrile transfusion, non-hemolytic febrile transfusion reaction. You can have allergic reactions. Any blood is also like a drug, isn't it? Like any other drug it can. Then if the donor has any of these infections, he can transmit this to the recipient. Bacterial infections, viral infections like HIV, protozoal infections like malaria and all that. Then during transfusion, you can develop an air embolus unless you're careful with the equipment. That is the tubing and all that, unless you make sure that you remove all the air and all that, or also so air embolus will come. Then the vein through which you're transfusing it can get thrombophlebitis, which any transfusion IV can produce thrombophlebitis if it is not carried out properly, especially with more viscid liquids like blood or things, more chances of developing thrombophlebitis. Then you have something called transfusion-related acute lung injury, TRALI, T-R-A-L-I, transfusion-related acute lung injury. This is a very uncommon complication, but it is almost 100% fatal. That is the problem. It takes place only very rarely. We'll discuss this also as we go along. The other complication that you can get is what is called a transfusion-associated graft versus host reaction, or TAGVRI. Now this graft versus host reaction, I think you must have all heard when you had those immunology classes for transplants, isn't it? Yeah, probably you know this better than I do. Anyway, yeah. So now what is happening here is, see, normally what happens when donor gives blood to a recipient, the recipient's body recognizes the leukocytes that are given, that are present in the donor as foreign, and they are destroyed. Understand? But what happens if the patient is immunocompromised? The recipient is immunocompromised. The body cannot put up a good defense. It cannot destroy the leukocytes in the donor blood. So what happens? The leukocytes in the donor blood takes advantage of this and attacks the lymphatic system, the leukocytes of the recipient. The reverse takes place. You understand? Usually it's the host that reacts to the graft, isn't it? In a transplant, here it is the other way around. The donor blood, that is the leukocytes in the donor blood, is reacting against the recipient's blood. So you get this graft versus host reaction. So this is commonly takes place in an immunocompromised patient, where the donor blood is immunocompetent. The donor blood is immunocompetent, but the recipient is immunocompromised. The other situation where this takes place is when you have a donor and a recipient with similar HLA, almost identical. Almost, there is a difference, but almost similar, not identical, similar HLA. So this is usually when the donor is a first degree relative. All of you know who first degree relatives are, isn't it? So when a first degree relative donates blood to this thing, if the HLAs are similar but not completely compatible, you get a graft versus host reaction. Yeah. So what are the clinical features? You will get fever, erythematous maculopapular rashes, then you can get toxic epidermal necrolysis, where the whole skin and the mucosa can get lysed and shed. Terrible condition. Yeah. Then you can get hepatomegaly, severe diarrhea. This is something. So how will you prevent this? The donor blood must be irradiated. You irradiate the donor blood using gamma radiation. That is how you can prevent this, which will kill off the leukocytes, and HLA problem will not be there. So this is what is done. Yeah. Then coming to we will go through all of these individually afterwards. Yeah. Then massive transfusion. What happens in massive transfusion? One, the blood volume. So massive transfusion, the problems that you can get is, I told you, coagulopathy, disseminated intravascular coagulation. That is, there is a breakdown in the coagulation pathway. The blood will not clot, so it continue to bleed, ooze or bleed. Yeah. Then hypocalcemia, because you are giving all those chelating agents, you can produce hypocalcemia. Hyperkalemia, because of the breakdown, stored blood, the RBCs tend to break down. There is releases potassium from the cell. You get hyperkalemia. Paradoxically, you can also get hypokalemia. Then I told you the blood is stored at low temperatures, isn't it? So if you don't warm it properly, and you massive transfusion, a situation where you require massive transfusion, you may not always have the time to warm it also up to the normal temperature. So if you give large quantities of blood with subnormal temperatures, you can get hypothermia. Hypothermia can produce acidosis. So it becomes a vicious thing, hypothermia, acidosis, coagulopathy. Coagulopathy, hypothermia, goes like that. So vicious. So one feeds on the other and it becomes worse. Finally, because of the breakdown of the RBCs, you can get repeated transfusions. You can get iron overload. This repeated transfusion is over a period of time, not a massive transfusion. Massive transfusion is a one-time affair. Repeated, like for example, a patient has hemolytic anemia, keeps on getting transfusions, you can develop iron. Now we will go through each of these complications. Allergic, we are now discussing complications seen after a Now see, after a massive transfusion, you can also get any of these reactions that you get after a single transfusion. You understand? Yeah. Don't think that you will get only hypothermia and this thing. You can get any of these things also. So when you have an allergic reaction, I told you it's like a drug. Just like any other drug, you can get allergic reactions to blood also, or blood products. So treatment is, you get itching and you can get urticarial rashes and all. That is a mild reaction. Treatment is, you give antihistaminics. Sometimes when you know that a patient has, people who require repeated transfusions, when you know that the patient has had allergic reaction during the previous transfusion, you can probably prophylactically give the patient antihistaminics to prevent it. Rarely these allergic reactions become life-threatening, they become very severe, where you get an anaphylactic shock-like picture, that is bronchospasm, glottic spasm and all that. And so what will you do in this situation? You will stop the transfusion, alright? And then you can give antihistaminics. You will have to give, you might have to use steroids and epinephrine. Understand? That is how you, just like any other anaphylactic shock. The other reaction that you can have, febrile non-hemolytic reaction. Here I am underlying the word non-hemolytic. You can get fever in hemolytic reactions, which is much more severe. Not the fever, but the problem that the patient has is much more severe. I'll come to that later. Anyway, febrile non-hemolytic reactions usually takes place within the first 24 hours after a transfusion. It is, the body's WBC, the recipient's body's WBC contains, the recipient's body is reacting to the WBCs derived from the donor. So this can be prevented by removing the WBCs from the donor blood. We will come to that later. So it's a response there. So here again you will have malaise, fever, nausea, headache. If you have seen a patient with patients with blood transfusion, this is a comparatively common problem. So in a patient who has had a previous reaction to febrile reaction to the leukocytes, you can the next time you can remove the leukocytes from the donor before you give it to the patient. This is what we talked about, acute hemolytic reaction or incompatible transfusion producing a reaction. This is a very dangerous situation. I told you this is mostly a human error, clerical error, which can be avoided. Or the antigen antibody reaction, that is what produces. So what you get here is you get nausea, chills, anxiety, flushing, chest pain, back pain. Now all of these individually, if you take, are non-specific symptoms. Nausea you can get with so many things. Chills you can get with anxiety you can just having a blood transfusion probably is enough to produce them. But all together tells you that this patient has a hemolytic reaction. Understand? The other things is during surgery or after surgery, what will happen is there might be excessive bleeding from the incision side, or there might be losing of blood from mucous membranes. Finally, it can lead to renal failure and shock and renal failure. So I told you, if you take this whole symptom complex together and you suspect a hemolytic reaction, the first thing that you will do is you will stop the transfusion. Alright? This also goes for non-hemolytic febrile reactions. Most of the times, non-hemolytic febrile reactions, we stop the transfusion and make sure that it is not a problem, and then restart the transfusion. Here, you stop it for good. You will not give that blood again, right? When you have a hemolytic reaction, and then you will check for the cross-matching again. You will do a blood count and a coagulation profile on the recipient to see whether he is going in for. And serum bilirubin again. Serum bilirubin will be elevated because of the increased breakdown of RBCs producing. So all these things you will check. And the treatment is, there is no specific treatment. What you do is you maintain good hydration. The kidney is the thing that usually fails first. So you get hemoglobinuria, you understand? Because of the breakdown of the RBCs, you get hemoglobin. So you will maintain intravascular volume. You will give general support, so BP will be supported and all that. Hemodynamic support. And I told you the idea is to preserve the renal function. So for this, you can hydration is the most important thing. You can probably use diuretics and alkalinize the urine. Now this backache in this situation is always ominous. A patient complaining of backache when he is getting a transfusion, always think of a hemolytic reaction. Probably it is due to the kidneys beginning to shut down. Sometimes you can get what is called a delayed hemolytic reaction. Now, when will you get a delayed hemolytic reaction? This, unlike the acute hemolytic reaction that incompatible we talked about, is not that serious. Not the, now, this is not due to the antigen-antibody reaction to the RBCs. The other one, hemolytic reaction, was due to antigen-antibody reaction to the RBCs. All right. Here it is not due to the RBCs, but to some other antigen-antibody reactions within the blood. So this particular recipient might have been exposed to the antigens present in the donor's blood in some other way, previously. So when he gets his donor blood, he gets there is a hemolytic reaction. But this is not as severe as an ABO reaction. Here also you get RBC breakdown, but it is not as severe. It is slow, gradual, takes place over many days, so it is not that severe. So here what happens is, the patient might show features of anemia after the transfusion when you do look at the blood. However, the patient might have an increase in the bilirubin. Mild jaundice after 1 week after transfusion, mild jaundice. You must think of a delayed hemolytic reaction. And usually this does not require any specific treatment. Then we come to a very dangerous condition called I told you this is very rare, but it is something you should be aware of, and from the exam point of view, very frequently asked. Transfusion related acute lung injury. This is associated with a transfusion of any blood component, but usually, most commonly with platelets and fresh frozen plasma. So this is what triggers usually any blood, whole blood, any other component can produce this, but it's most commonly seen with this. So what are the symptoms that the patient will have? Patient will have dyspnea, hypotension, hypoxia, because it is injuring the lung, isn't it? Dyspnea, hypotension, hypoxia, fever, and the finding that you will get is, you will get bilateral pulmonary edema, which is not due to a cardiogenic cause. You understand? So that is what is the most important. That is what differentiates it from cardiogenic causes. So that is how you diagnose it. So because a patient who is supposing a patient has a history of coronary artery disease, his heart is already weak. When you give a transfusion, you might overload the heart. You can go into congestive cardiac failure, which can reflect as pulmonary edema. You understand what I mean? Yeah. Or the patient might develop a acute respiratory distress syndrome, either because of his initial disease process or because of the transfusion. Initial disease process. In which case, again, he will have features suggestive of, all these features will be there, isn't it? Dyspnea, hypotension, suggestive of, So you have to rule out a cardiogenic cause or adult respiratory distress syndrome. Only then will you say that this patient has transfusion-related acute lung injury. So it is a diagnosis of exclusion, but you must suspect it whenever you have any of these symptoms. So what is happening here is the donor antibodies are attacking the recipient's leukocytes, you understand? And then this within the pulmonary arteries, and now this is releasing cytokines which is attacking the epithelium of the pulmonary arteries, which is making the pulmonary arteries leak out all the fluid into the lung spaces. That is how you get the pulmonary edema. Treatment here is again supportive, that is you hemodynamic support. You might have to put the patient on a ventilator, you might have to give drugs to counteract the shock and all that. Then I told you the patient can get the recipient can get infections from the donor blood. Now this I think is there is no need for me to go into detail. Obviously, if the donor has HIV, the patient can get HIV. If the donor has HCV, the patient has malaria, So, but you will screen for all this before you collect the blood from the donor. All right. Only this I already discussed in the beginning. This is all very important. I know this is not what you will do, but it's the blood bank that will do it, but it has to be done. But final responsibility is the treating physician. So, Then we come to the problems with massive blood transfusion. See, when will you say the patient has had a massive blood transfusion? If the patient's whole blood volume has been replaced within 24 hours, or he has received blood equivalent to his whole blood volume within 24 hours. Normally a person has a blood volume of about 5 liters, isn't it? So if within 24 hours you receive, if a patient gets 5 liters of 5 liters about 10 units, I told you each unit is about 450 ml. 10 units of blood, he's had a massive blood transfusion. Yeah. So with this, because of the quantity, the patient can have congestive cardiac failure. So that is one thing that the patient can have. He can have coagulopathy. I told you massive blood transfusion, there is always a chance that the coagulation factors will fail and you get what is called disseminated intravascular coagulation. That is a problem. Because the blood is stored at low, all these things I already told you, because the blood is stored at a low temperature, when you give large quantities, the patient can develop hypothermia. Yeah, so all these things can, then the patient can develop citrate toxicity and all that. Then I told you electrolyte imbalance, because all that. Hyperkalemia, hypokalemia, hypocalcemia, all these things. So you can, hypocalcemia will correct by giving calcium, IV calcium, like that. So all this can be corrected. Yeah. So now we were discussing, homologous or allogenic, that is same species, same genus but different species. So I donate blood for you, it is the same species but different, same genus but different species, isn't it? Yeah, so that is called allogenic or homologous. Now there are certain alternatives. Supposing you don't want to use this because of all these problems that we talked about, you want to avoid that, you can, there is an alternative to that. That is, you can give autogenous. You know, how do you give autogenous? Autogenesis, you pre-donate the blood. This can be done only in an elective. I am talking about surgery here, you know. So in an elective surgery, you have already decided that you are going to have the surgery. So you donate, the patient himself donates his blood about 3 weeks prior to the surgery. Now this is stored, and during surgery, this blood is given to the patient. When the patient has bleeding, this is given to the patient. This is called autologous transfusion or autologous pre-donation. There are other ways of autologous transfusion. Autologous pre-donation. So you have donated, the patient has donated his own blood 3 weeks prior to the surgery, and then that is given during the surgery. So this, the problem with this is, again, it is cumbersome, isn't it? Donation, preservation, and again, all those clerical problems, clerical error problems can take place. Patient A has donated the blood 3 weeks prior to the surgery, and is undergoing surgery today, and he gets blood which was pre-donated by patient B. Then the whole business of hemolytic reaction sets in. So it is a problem that way. And storing it, you have to store it. I told you the temperature is low, you have to store it at low temperature. All sorts of logistical problems are there. All right. Then there is something called isovolumic hemodilution. Here what this previously autologous pre-donation, you did it 3 weeks prior to the surgery. In isologous hemodilution, what you do is just before the surgery, for example, the day before the surgery, the patient donates blood, say 1 unit of blood. You can't use it for large quantity, just 1 unit at a time. 1 unit, so 450 ml, and you replace this by isotonic saline or inhalactate solution. So the patient's blood volume is maintained, but he has lost whole blood, 450 ml of whole blood. And this blood during the surgery can be used. That is called, So this can be done. You can use this for till the patient's hematocrit. PCV comes down to about 32. 32 will be about 10 grams. HB of 10 grams up to that. So not just 1 unit, 1 or 2 or 3 units up to, you can use it like this. Then there is something called intraoperative autotransfusion. What is done here is during surgery. This is typically described in patients who have ectopic pregnancies, young females, childbearing age group. They develop a pregnancy which is outside the uterus. There's ruptures, you get massive hemorrhage, patient goes into shock, you open the abdomen, you find it is full of blood, and then you don't get that much of blood immediately to transfuse. What you can do is, you can collect this blood from the abdomen, send it through a cell separate and send it through the blood cleaning apparatus is there, and then auto transfuse it. So the blood that is taken from the abdomen of the patient is recycled into the patient after cleaning it. You understand? So this is usually typically described, most commonly discussed in relation to ectopic pregnancies. You can use it in other situations also, whether there is a massive hemorrhage, like for example, a ruptured aortic aneurysm, for example. I'm just giving an example. You can probably use this. But you cannot use it if the blood is contaminated. Either supposing you're doing some surgery, you have made a hole in the large bowel, and then you try to collect the blood, you collect that blood, obviously it is contaminated, you can't use it. So clean blood, that is why I said ectopic pregnancy is the example that is most commonly given, because that is usually, otherwise no contamination. Yeah. So we talked about autologous pre-donation, hemodilution, and autologous transfusion, intraoperative transfusion. The other way in which you can increase the RBCs is by giving the patient erythropoietin. You understand? All of you have studied physiology, you know what erythropoietin does, isn't it? It increases the RBCs in the blood. This is another technique. So this can be used. So what you do is you give erythropoietin injection subcutaneously every week for about 4 weeks prior to the surgery. So that will increase the RBCs in the patient. So and then you can do surgery. So even if there is a bit of, there is moderate degree of blood loss, it will not affect the oxygen carrying capacity of the blood. This is especially useful in chronic renal disease, where again usually these people have anemia because of erythropoietin production in the kidney and all sorts of stuff. So so these patients benefit from getting erythropoietin. Then I told you about blood substitutes.
17
so ഞാൻ എടുത്തരാം. പേരുകൾ എനിക്ക് ഓർമ്മയില്ലല്ലോ, ഒരു കൺഫ്യൂഷനാണ്. അന്നക്കാട്ടിട്ട് ഞാൻ തരാം. ഞാൻ പറഞ്ഞോളാം. Yeah, sorry. So what I was saying is you have blood substitute. I told you this is in the experimental stage. We still do not have a useful blood substitute. I told you blood substitute not to replace the volume but to increase the oxygen carrying capacity. So now there are two ways in which this is being tried out. One is hemoglobin based, that is derivatives from hemoglobin from other sources, hemoglobin from other sources. Try to modify it to carry blood and it can be transfused. The other is perfluorocarbon. They use this particular molecule. They are trying to modify it to carry oxygen. Yeah. So these are the blood substitutes that are being tried out. You can read all these articles. You can get it online if you are interested. Now I wanted to discuss a few things that we already discussed which might not be clear. So massive blood transfusion, I told you the definition. When will you say a patient has had a massive blood transfusion? Replacement of one blood volume within 24 hours. I told you in a normal person the blood volume is about 5 liters. So either 5 liters or 10 units, because each unit of blood I told you is 450 ml. Yeah. Or if there is a transfusion of 50%, more than 50% within 4 hours, that is also called massive blood transfusion. In children, they usually about 50 ml per kg within 4 hours. So this is about massive blood transfusion. Yeah. So the other thing that you must remember is when you give a massive blood transfusion, I told you blood components, not whole blood. When you give blood components, you are giving RBCs. Mainly I told you give RBCs. So but when you give RBCs, you will not give RBCs alone. Along with that, you will give fresh frozen plasma and platelets in the ratio of 1:1:1. So for each unit of packed RBCs, you will give 1 unit of fresh frozen plasma and 1 unit of platelets. This ratio was different in the past. This is the present ratio that is followed. So I think these things keep changing as we learn more and more. These things keep changing, but this is the present protocol. So in a massive transfusion, you will give the blood products in this particular ratio. If you're giving whole blood, there is no problem because there is no need to, but when you give components, this is the ratio that is followed. Red blood cells is to fresh frozen plasma is to platelets in the ratio 1:1:1. Then these are some things that we, apheresis, you keep hearing about apheresis when we talk about blood donation. And what we mean by apheresis is you take the blood from a donor and you take only the particular component that you want, and then the rest of the blood is put back into the donor. You understand? Now, for example, I want to give a patient platelets, and I have a donor who is fit to give it. What I do is I want only the platelets, so I'll remove only the platelets, and the rest of the blood I transfuse it into the donor. This is called apheresis. So you can have leukopheresis, you can have plateletopheresis, like that. Anything can be extracted. Yeah. No, this is not simple, what should I say? This is not like, you have wheat and rice mixed together, separating wheat and rice. That is comparatively easy problem. It is not an easy, there are a lot of techniques, technical details here which I will not go into because I am also not very conversant with it, and probably it is not necessary for us. We will believe or we will trust our blood bank to have done the correct job. Yeah. Then you have something called leukocyte depleted blood. I think I have this thing on that. Yeah. This is now what is leukocyte depleted blood again? Okay. In leukocyte depleted blood, you remove the leukocyte layer. There is something called the buffy layer. When you centrifuge the blood, you get something called a buffy layer which contains the leukocytes. You can remove that and then use only the remaining thing. So this is what is called leukocyte. Why do you use it? See, I told you we talked about non-hemolytic febrile reactions, and we said that this is because of the reaction of the recipient to the donor leukocyte, isn't it? So if a patient has already had a blood transfusion and as he had a severe non-hemolytic febrile reaction, next time when the patient gets a blood transfusion, you would like to prevent it, so you will give blood where the leukocyte has been removed. The other situation is in patients who have already been HLA immunized. You understand? There also you would like to. Then where there is it can minimize the platelet refractiveness. When patient, I told you massive blood transfusion, there is a coagulation problem. One of the problems is because of, besides the coagulation factors, one of the problems is the platelets are not functioning properly. So here also you can give leukocyte depleted blood, which will prevent that. The other advantage is when you think that a patient has, that is a donor has a cytomegalovirus. So this blood can be used by removing the platelets because the cytomegalovirus is a leukotrophic virus, isn't it? So when you remove the leukocytes, cytomegalovirus is also removed. So this is another indication where you use leukocyte depleted blood. Then there is something called irradiated blood. Sorry, this heading is wrong. Irradiated blood. Advantage of that is it prevents the graft versus host reaction, which we already talked about. Graft versus host reaction, where the leukocyte of the donor is attacking the recipient. You understand? Usually it is the other way around. So yeah, so this is usually seen, I told you, when there is HLA, similar HLA relatives, blood relatives, or an immunocompromised patients where they cannot reject the donor or leukocytes. So this is indications for giving irradiated blood, and how you use gamma rays to irradiate it. All right. That completes blood and blood products for the day. Thank you.